Hi there, and welcome to a session overview of cognitive therapy for depression, which was based on a model written by Beck. So, when I was training and practicing as a cognitive therapist, I really just wanted someone to tell me roughly what treatment looked like, because the cognitive therapy protocol seems it's a little bit more exploratory and can take a different path. So it's not the kind of protocol that says this is what you do session by session. And although I don't really feel like I need this guide now, I feel like I can just fit into the flow of the patient a bit more. But certainly at the start, I was really baffled. What does this look like in real terms? What do I do in each session? And I found it really quite easy to get lost in cognitive therapy, which wasn't really very helpful for the patient. So even though this might be, I hope it's not going to be laborious. I will try not to make it laborious, but I suppose it might feel a bit dry, but I think this is going to help you no end if you are offering cognitive therapy. So yeah, I hope you find it useful. If you're practicing, I'm sure you will. I'm really sure you will. Okay, so what does I'll go for a typical session in cognitive therapy, and then I'll talk to you about session by session and how they differ. So a typical session in cognitive therapy looks where you will collaboratively kind of set your agenda for the session. So this starts with, what would you like to put on our agenda today? Now, it's really important that you ask a patient, what would you like to put on the agenda today, rather than, is there anything that you want to put on the agenda today? Because invariably to that latter question, they are going to say no. So a patient will be encouraged as time goes on to put some points on the agenda that they would like to discuss. So the next thing that you do is to assess their mood. So you want to understand a subjective report of their mood, and you may sort of ask them to provide rating scales or what have you, depending on the homework that you've set. And you might ask them to review recent incidents or events and do a quick review to promote understanding and that link between thoughts, feelings and behaviours. So you would then review homework in every session. If you ever set homework for a patient or between session work, then it's really important that you give them time and space to talk about this and reinforce their efforts. So you want to review the homework that you set from the previous session and reinforce that progress. And then you will discuss anything that your patient has put on the agenda, perhaps any issues or incidents that have arisen since the last time you met. And based upon that, you will review them, but you'll also introduce or review a specific skill that will address these concerns. And I will talk about these in the next few chapters. So once you've done that, so that would be referred to as a change technique. And once you've done that, you would then formulate a homework task. And as you do that, identify any factors that might interfere with their success of completing it. Now, in cognitive therapy, we've talked about collaboration when we were talking about assessment. So it's really important to help a patient summarise the main points of the session and conclusions. And I always find it really useful to understand what a patient's learning point was from the session. So what did you learn? What do you know now that you didn't know at the start? And it's also good to get feedback on the session as well. How did you find the session today? And understand their thoughts and feelings about the session. And this will create a really nice open dialogue between you and the patient, so that they can give you feedback which again is another really important element and something you will find in the cognitive therapy scale revised. So that's what a typical session looks like in cognitive therapy, but it develops throughout treatment. So let's start at the beginning. So it's following your assessment, you've done your assessment. So let's call this session 1 then as your treatment session. Now, Beck uses a measure of depression, which is not something that I use personally. I use a patient health questionnaire, the PHQ-9, which is a 9-item depression scale. And I also use the GAD-7 measure of anxiety as well. But Beck has the Beck Depression Inventory, and that's what Beck uses and encourages people to use to measure depression in a psychometric, self-rating kind of way throughout treatment, and that can give a really good understanding about where the patient's at and how much this treatment is working. So I would always inquire about the patient's expectations in therapy, what they're wanting, what they expect, and I can dispel any myths or encourage them or work with any ambivalence in what they're experiencing. I try and in that first treatment session, I also try and elicit negative attitudes relating to themselves, therapy, or myself as well. I've had, it springs to mind a particular patient who was an older gentleman who, was concerned about my age and experience. So I think it's really good to open that up and talk about it and address it while you can. And then from the outset, at the very beginning of treatment, Beck says it's really important to pinpoint the most urgent problem. So a patient might be experiencing a particular problem that needs dealing with now. So that's obviously got to be priority. Risk certainly comes under that. So I would review symptoms, and Beck also says that it's important to assess suicidal ideation and hopelessness at the outset. So the other functions of the first session is to discuss links of thinking on behaviour, and just spend some time with a couple of examples linking this is what I thought and this is what I did. So you're promoting that understanding between the link. And I would often set an activity diary as the first homework, which is a little bit different to behavioural activation in its true sense. So this is more trying to establish whether the patient has a mix of kind of activities that will bring them a sense of mastery and pleasure. But I suppose for Beck, it's about making sure that they have a good activity level, they have a good routine, but it's also used in order to understand really what their thoughts are. So it can be a really good talking point around perhaps enjoyable activities that they did, but they weren't feeling very good at the time, and they had a low kind of sort of negative emotion rating. And then you can delve into that and discuss what their thoughts were. Now at the end of that session, Beck has a printout that you can find. It's readily available online, and it's a handout explaining what depression is for the patient. Okay, so that's session 1. In session 2, you'd do the questionnaires. So you do the questionnaires in every session. So I'll just leave that right there so I don't have to mention it again. You'd review the patient's symptoms since the last time you met. You'd review the activity schedule, looking at any distortions, as I said, or even omissions in the diary to see what stopped them, what thought got in the way. And then I'd introduce further that relationship between thoughts, feelings and behaviours. And this is when you want to go into a more detailed incident analysis depending on what's happened in their week. And then you set the homework. So this would be the activity schedule again at this stage. And I think that's that. So session three, you'd review those mastery and pleasure ratings on the diary. You want to elicit those thoughts related to emotion, and think of some real examples of emotions with the thoughts, so that a patient really starts to understand those links. And at this stage, a patient is usually starting to grasp that link between thoughts and emotions and thoughts and behaviours. And then you set the between session sort of task, which is to record cognitions this time related to the different emotions. And really you want to support a patient to think of a range of emotions to capture, so not just kind of depression, but maybe sadness, anxiety, apathy, but also any positive emotions that they might be experiencing, because as I said, we want to sort of home in and capitalize on their ability to sort of cope and adapt as well. So session 4, we set the agenda. We look at cognitions that lead to more unpleasant effect, and you want to discuss sort of how negative automatic thoughts are distorted and related to depression. Now this is a new concept, and this will be really quite brand new for the patient, so it can take some understanding, some work. You want to do an incident analysis to really make this real for the patient. And then, as before, you set your homework. This time, it just continue to continue to record cognitions, and you may want to help them start to record alternative explanations for their thoughts, having introduced that idea that these cognitions are distorted. So session 5 is very much the same format. We review the scheduled activities as well, and you really want to be focusing now on the mastery and pleasure. You want to keep reviewing, discussing those NATs. You want to keep demonstrating those, challenging those thoughts. And then sessions 6, 7 and 8 are really quite similar. So again, continue to identify those thoughts, further kind of rationalization using Socratic questioning, those cognitive sort of therapy skills, thought challenging, and of course we'll talk more about all these skills later. But it's at this stage, this stage later in therapy that you may start to discuss some basic assumptions. Okay, so go back to that chapter in Beck, because I think it's really worth reading. I think it's chapter 12. So you want to discuss those basic assumptions, and again, it's about hypothesizing at this stage. If you've kind of cottoned on to sort of any kind of core things or assumptions that really are sticking out for you, that you think that are more patterns in the patient's ways of coping, then this may be a good time to bring it up and discuss. So you want to discuss those cognitions, and as I say, discuss or identify at least any of those recurrent common themes. Some examples of these might be kind of I should be doing this, so shoulds versus wants. It might be high expectations and perfectionism traits, and you're really theory building at this stage, looking at rumination, any unrealistic general goals. So identifying and bringing these into the open. Okay, so sessions 8 to 12. 8 to 12 look like an increasing delegation of the agenda to the patient. So the patient has more responsibility in your sessions. So again, more responsibility with setting homework. What do you think you should do for homework this week? How do you think you can do that? Can you think of any barriers that are getting in the way? So the onus is a bit more on the patient, and this is really important. It's really key because you're teaching your patient to become their own therapist. This is not a long-term therapy or cognitive behavioral therapy, and this is why it's so good, because you're teaching a patient the skills that they can go away with and practice for life. Okay, so yeah, we're on sessions 8 to 12, weren't we? So we also want to identify and discuss kind of dysfunctional assumptions if you can, and at this stage you might go one step further to start testing their validity, and you can do so through behavioural experiments, and there are some other discussional techniques you can use, which I'll talk to you about later. And then sessions 13 to 15. So this is really, you can go up to 20 sessions with cognitive therapy, but these sessions are really focused on that preparation for discharge, the emphasis on the continuation of homework and the continued learning process. And you want to, I suppose, anticipate what problems might come up and get the patient to rehearse those coping strategies, making sure that they can do that independently. And then the final session, whatever the session that is, but let's say call it session 20, might be consolidation of gains, really understanding and putting into a plan. How am I going to maintain my progress? I prefer that to relapse plan, because I think we are all works in progress, aren't we? So a plan for maintaining progress and a plan for follow-up. You may wish to follow up with a patient in a few weeks or what have you. So I think that is everything. So I hope you have got a lot out of this. I hope it wasn't too boring, but I hope you have got a lot out of it. And I would ask you to kind of go back, make some notes, and I really hope that this will guide you throughout your next treatment offering cognitive therapy for depression. Thanks for listening.